Great. Thank you, everybody, for making time to listen to this presentation today. I think you're going to find it fascinating. This is a session on stages 1 through 3 renal cell carcinoma. For many of us who are in my stage 4 renal cell community, we spend a lot of time on stage 4, but this one really is focused on those with stages 1 through 3. And I'm really proud and happy to have an amazing panel lined up. But before we start, a little bit about our sponsor, the amazing Judy Nicholson Foundation, led by Linda Anderson, who's with us today. The Judy Nicholson Foundation's mission centers on empowering and enriching the lives of those affected by kidney cancer, whether patients or loved ones. They focus on providing comprehensive support and education through symposiums, panels, and online Facebook community, and our yearly celebration of life, where we get together in person to celebrate living with this disease. And if you haven't heard about this, feel free to let me or Linda know. The next one is in August in Williamsburg, Virginia. I started this 4 years ago in Chicago, and it's grown every year thanks to Linda and Judy Nicholson taking it over for me and just doing a great job. But to see those with renal cell carcinoma and their loved ones smiling and celebrating life is a sight to behold. We also host monthly open patient and caregiver forums. I have had the honor of hosting the open patient/caregiver forum for now 3 years and counting. Again, it's a great way to talk privately and informally with patients and caregivers. But you just heard a little from me about the Judy Nicholson Foundation. Go to their website and take a look. There's so many great panels coming up in the near future. One that's coming up in June on probiotics and the effect on immunotherapy, which I personally will find very fascinating. But their website is jnfkidneycancer.org. Before we dive into questions, I'd like to briefly introduce our panelists, all from a hospital I believe we are well aware of, MD Anderson. I'll start with Dr. Brittany Cotta. She's a urologic oncologist specializing in the surgical treatment of cancers of the GU system, with expertise in both open and minimally invasive robotic surgical techniques. She earned her medical degree from Southern Illinois University School of Medicine in Springfield, Illinois, followed by an internship in general surgery and residency and chief residency in urology at the University of California, San Diego. She then completed a Society of Urologic Oncology accredited fellowship at Memorial Sloan Kettering Cancer Center in New York, and an HT32 research fellowship at my school, University of Michigan, or at least my favorite school. Dr. Cotta has numerous publications in peer-reviewed journals, and her research interests include molecular characterization and biomarker development in kidney cancer. She currently holds a faculty position as assistant professor in the Department of Urology at MD Anderson Cancer Center in Houston, Texas. Welcome, Dr. Cotta.
Thank you for having me.
Next up is Dr. Chad Tang, who I've had the pleasure of meeting in Houston at a symposium last year. He is a radiation oncologist at MD Anderson Cancer Center and an associate professor in the Department of GU Radiation Oncology. He has joint appointments in the Department of Investigational Cancer Therapeutics and Translational Molecular Pathology. He received his MD from Stanford University and completed a residency at MD Anderson Cancer Center. His research and clinical practice focus on the treatment of advanced prostate and renal cell carcinomas, with an emphasis on oligometastatic and oligoprogressive patients. And by the way, Dr. Tang, I think when we talked, I was one of those oligoprogressive patients for the last few years. He has completed and continues to run several investigational initiated clinical trials investigating these diseases with an emphasis on translational correlatives. Welcome, Dr. Tang.
Thank you.
I will now move on to Dr. Pavlos Msaouel, who most of us know one way or another. He's a physician scientist dedicated just seems, this should be a stronger word, to kidney cancer research, with a particular emphasis on rare subtypes such as renal medullary carcinoma. His laboratory identified the serum biomarker currently used to monitor cancer burden in most patients with renal medullary carcinoma, as well as many of the targeted therapies currently used for this disease. These discoveries were accelerated by his introduction of modern data science approaches to research and clinical practice. He serves as the principal investigator of several completed and ongoing clinical trials Thank you, Dr. Msaouel, for rare and common kidney cancers, including the first such trials designed specifically for renal medullary carcinoma. Pavlos is an active and passionate contributor to several kidney cancer organizations, including the Judy Nicholson Foundation. Welcome, Dr. Msaouel.
Thank you so much for having me.
You're welcome. Dr. Abdelsalam is an interventional radiologist, currently serving as an associate professor in the Department of Interventional Radiology at MD Anderson. Dr. Abdelsalam's clinical practice focuses on minimally invasive percutaneous therapies for renal and liver cancers, particularly kidney ablation and liver radial embolization. I'm doing pretty good with these medical words. Since 2015, his research has primarily focused on kidney cancer, concentrating on the long-term outcomes of renal ablation across various clinical scenarios. His research has been presented at renowned conferences such as SIR, ASCO, and AUA, and others. He has contributed over 100 publications to the field of interventional oncology, including peer-reviewed articles, abstracts, and book chapters. He's currently a collaborator on more than 30 clinical trials at MD Anderson. In addition to his clinical and research expertise, Dr. Abdelsalam has been dedicated to education, earning the Teacher of Year Award in 2020 for his exceptional contributions to training next-generation interventional radiologists. Welcome, if you are here. I don't see him yet. We're working on him, Linda. We are going to start with the 3 panelists, and hopefully we'll get the 4th. The way this is designed is I have a series of questions that I've shared with the doctors, and they've communicated an interest in responding to them. If you have questions, please put them in the chat line. Linda and I think Marlene is going to help figure out the questions we're going to take at the end of the session. So we've left plenty of time for that. So with that, it's game time. Let's start. First question is for Dr. our urologist. What are the surgical options available for patients with stages 1 through 3, and how are these decisions best made, Dr. Cotta?
Sure. So first, I think I have to discuss what stage 1 is in 3, 1, 2, and 3. So there's stage 1A, which is a localized renal tumor that is less than 4 centimeters, and it is not involving the center of the kidney or the renal sinus. Sometimes a tumor can actually be stage 3 even if it's small, if it involves the center of the kidney, the renal sinus fat. And then stage 2 is just a tumor that is less than 7 centimeters, but over 4 centimeters. So size and location is really important. And then tumors that are about less than 3 centimeters have a higher chance of being benign or indolent, slow growing. So oftentimes we recommend even active surveillance or not any treatment at all. And then sometimes we offer some minimally invasive techniques, which Dr. Abdelsalam will discuss. But for surgery, if we decide that we want to go forward with surgery, doing a partial nephrectomy would be the treatment of choice for a stage 1A. That's just removing the tumor and a rim of healthy tissue in the kidney, affected kidney. Your renal function doesn't change once the kidney is healed from surgery. It's a pretty low complication rate for that size, and the oncologic outcomes are very good, the same as if you were to remove the whole kidney, which we generally do not do for tumors that are small, less than 4 centimeters. Stage 2, size 4 centimeters to 7 centimeters. Sometimes I will do partial nephrectomies on those as well, especially if they are, what's the location, exophytic, so meaning big but growing off of the kidney instead of into the kidney, especially if somebody has pre-existing kidney disease. Then there's a really good reason to avoid a radical nephrectomy. I will do those. And then for same reasons for some stage clinical T3A, if it's a small tumor and maybe it is growing into the renal sinus, but not the renal vein, sometimes I actually will do a complex partial nephrectomy on that as well. If the patient has a solitary kidney or if they have pre-existing kidney disease, or it just looks like it'll be very feasible. And then if we're not doing a partial nephrectomy, let's say the tumor is central, so invading the renal sinus and renal vein, even if it's stage 1, 2, 3, stage 4, we can do a radical nephrectomy if the patient has a healthy contralateral kidney, or sometimes even if they don't, if it's an aggressive looking tumor that just can't safely be removed via partial nephrectomy.
Dr. Cotta, I'm being spontaneous. I can see the chat line questions. So when a question pertains
Sure.
to what you just asked, I'm going to repeat it.
Yes.
This is a question that came out. My surgical urologist said I have a 70% chance of having RCC from all of his experience. Why did the doctor want to wait 6 months to do another MRI to see if it's growing? Do they not like to operate and remove the cancer? I'm 66 female because they figure something else will kill me before the RCC.
So there's actually a really good outline on, I think, the KCA website, patient information. It's really tricky. I'm assuming that this tumor urologist is talking about is probably stage T1A, maybe 2 centimeters. In that instance, there is like a 30% chance or so that it could be benign. And we don't really like operating on anyone for benign tumors. So if we do a active surveillance approach or sometimes delayed intervention, we can wait 6 months, see if the tumor grows a few millimeters. And if it doesn't grow at all, we're reassured that it's probably benign. Maybe you don't need surgery ever. If it does grow, let's say 3 millimeters, 5 millimeters, then we're more convinced that this is probably a renal cell and we have more information and we feel more comfortable just going in and doing surgery then. So I'm assuming
That refers back to what you earlier said, that size and location matter, right?
size matters a lot. So if your tumor was 5 centimeters, 4 centimeters, 3.5, once we get a little bit closer to the stage T1B, we are, sorry, I think I misspoke. T1B is 4 to 7, T2 is 7 centimeters or greater, and T3 is when you have, regardless of tumor size, some growth in the center of the kidney. So yes, so T1A surveillance is often a good approach to start out with.
So
Maybe you won't get surgery, but it probably means we don't need to go to surgery just yet.
we talked about tiny tumors. Another question, how rare is a tumor over 20 centimeters? And do you always recommend that size be removed immediately?
That is pretty rare. 20,
Sorry.
20 centimeters, we've seen it usually closer to 15 or so. Patients usually start to have symptoms, but yeah, if it's 20 centimeters and it's, even if it's maybe stage 4, but if it's stage 3, mostly radical nephrectomy would be recommended up front.
Thank you. Linda, let me know if Dr. Abdelsalam comes because I can't see him. So I'm going to refer more questions to Dr. Tang. So Dr. Tang, how about non-surgical options, radiation, ablation, wait and watch, which Dr. Cotta alluded to earlier?
So that great questions. Wait and watch, as Dr. Cotta mentioned, is most appropriate for small tumors. There's various numbers that we can look at, like 4 centimeters is a number where once we start to get above that, we start to worry more about the malignant potential. So sometimes you'll see that in different guidelines, 4 centimeter below, we can watch. More than 4 centimeter, we may want to treat. Speaking of radiation, because that's what I do, it's the newest gender block. It has the newest data on it because the advanced radiation technique has now allowed us to focus extremely high doses of radiation very precise in the kidney without damaging the surrounding organs, or at least minimizing the damage to surrounding organs. The recent data is very promising, but I would say it is newer, so there's not as much of a track record. But it is a non-invasive way to control kidney cancers localized, and it generally preserves possible a lot of the healthy remaining kidney that's left over. I don't know if you want me to talk about higher ablation, but I don't do that. But
yeah, anybody, Dr. Msaouel, if any, or Dr. Cotta, if you can speak to ablation, because that seems to be riding a wave of trend. More and more people are interested in it.
Yeah, I can talk about that because sometimes I'll be the first person or the second person to see a renal mass. And if we're looking at small renal masses, and I think that maybe it's closer to 3 centimeters or so, maybe we've done surveillance and the tumor is growing, and then we're deciding on treatment. So usually it's partial nephrectomy versus ablation. Some things that push me towards ablation is the patient's comorbidities. It is definitely less invasive. Still requires general anesthesia, but there's no big incisions, even robotic surgery, which how I do my partial nephrectomies and most of my radical nephrectomies is more invasive than a needle poke for ablation. The location, again, matters a lot for ablation. So the tumor should be on the back of your kidney because the interventional radiologist pokes the needle through the back. So that's important. It has to be away from other organs. so there's no damage to other organs while they're either freezing or burning the tumor tissue. The type of tumor doesn't matter so much. How deep it is can matter. It's probably better for the interventional radiologist to have a tumor that's growing like a pimple on the kidney as opposed to growing in very deep, because that just puts the kidney further at risk for complications. And I think I mentioned comorbidities, advanced age. Sometimes patients can tolerate ablation better than they can tolerate a major surgery. And then the important downside for ablation is that there is a slightly higher chance of recurrence, just meaning that all the tumor tissue wasn't ablated. So we have to do close surveillance afterward. And if there is any tumor regrowth or missed tumor, then that can actually be reablated. And then occasionally, if need be, a partial nephrectomy or a radical nephrectomy can be done to control the tumor.
Great. I will offer this up to anybody who would like to answer it. Can you talk a little bit about clear cell renal cell carcinoma PT3A with fat invasion? I don't see a lot about the impact of the fat invasion, much more about renal, vein, et cetera. I don't know the answer to that. I'm interested. So, anybody? Probably Dr. Cotta.
Yeah, I can talk about that. So that comes up a lot. I've been doing more and more kind of deeper T3A tumors because the renal sinus fat is just fatty tissue that is in the middle of the kidney, and the tumors can butt that. We can still take it out safely and take a rim of that fat. The pathologist then looks at it, and sometimes there can be microscopic invasion to the fat. It's not as strong of an adverse marker as, say, renal vein involvement or segmental renal vein involvement, but it does change what could have been a stage 1A tumor just by size alone to a stage 3 tumor. So we do look at that, and increases your chance of recurrence a little bit, but there's also other factors we look at, such as the pathology stage and grade, and if there are any other adverse features. And then overall size. So if this was a T1 tumor that became T3 because of the renal sinus fat, that's a better prognostic marker probably than if you had, say, a 7-centimeter tumor plus tumor sizes is pretty important. So not a straightforward answer, but it's just one of the prognostic markers we do look at.
By the way, I just want to mention it at this time because patients and caregivers are not going to retain everything that we all talk about today. The KCA has an amazing website for new patients. Please look at that. The other one that I absolutely love is the NCCN patient renal cell. Is soup to nuts, basically provides a wealth of information. And for those of you on my stage 4 community, I have shared that with all you guys. Happy to, if you DM me or let me know otherwise. Dr. Msaouel, we've been very patient. Do these options change if the patient has a high grade or rare subtype?
Definitely the consideration changes a lot depending on the type. So, for example, an easy one is if you have renal medullary carcinoma, the cancer that, as you mentioned, is a deep focus of us, a very aggressive, angry type of kidney cancer, then we don't like to start with surgery in the vast majority of cases, whether it's a stage 3 or stage 2 cancer. It's very rare that we will start with surgery removing the kidney in renal medullary carcinoma, which is the complete opposite from what with the most common kidney cancer, clear cell kidney cancer. So that those two extremes tell you immediately that absolutely the type plays a big role, which is why it's important whenever possible to know what kind of kidney cancer you have, because there's many different ones. Grade can also influence how you think about things. It doesn't necessarily change the repertoire of options as much as type can, but definitely any information can be helpful with tailoring our approaches for each patient.
And more specifically, what about confirmed genetic mutations like HL-RCC, renal medullary cancer, RMC, CHRCC, some of the real rare genetic mutations?
Yeah, that's a good question. And that's actually a great opportunity to clarify something important. When we're talking about genetic mutations, we're talking about things that have changed in the DNA. And most people know what the DNA is and how it's essentially the code that then gets transcribed into RNA, that then gets translated into proteins that are the building blocks of cells. That we know. And so it's very important, that cool. But those mutations can be divided roughly into two different types. One type is what we call the germline. That's the fancy medical term. Germline mutations are the mutations that you have in every cell of your body, not in your cancer cell only, every cell in your body. Those are the germline mutations that are associated with genetic syndromes. And then the other big type of mutations is what we call somatic mutations. Those are the ones that happen specifically in the cancer cells. So some kidney cancers are associated with germline mutations. So for example, this is a big difference, and I see patients confuse that all the time. Let's start with the big one, VHL. You may have a VHL germline mutation, which means that you have the VHL genetic syndrome. The mutation is everywhere in your body. And that increases your risk for clear cell kidney cancer because that's the one associated with VHL mutation, whether germline or somatic. And it's associated with the risk of other tumors like hemangioblastomas and other things associated with the syndrome. So that's different. That's a genetic disorder. But then most clear cell kidney cancers, whether they're associated with the VHL germline syndrome, will have VHL somatic mutation. That's different. When you have a somatic mutation, then that's only on the kidney cancer. So very often patients confuse that and they see the VHL somatic mutation and they say, oh my God, I have the VHL syndrome. No. And so the same goes with many of the others. So for example, renal medullary carcinoma, it is defined always by a mutation in a gene named SMART-B1, but the key here is that it's a somatic mutation, not a germline. We've never seen thus far a patient with RMC that has a germline SMART-B1 syndrome. FH deficient RCC fumarate hydratase is another one that I know has been discussed a lot in the foundation meetings. And that one again, you may have the germline FH mutation, in which case you have the HLRCC syndrome. But in about 20% of cases, you may not have the syndrome, but have it only as a somatic mutation in the tumor, in which case you just have the cancer, the FH mutation. So these are nuances that are very important because they guide management, they guide even recommendations for your family, and not just for the management of the patient themselves. So
very helpful. And by the way, welcome, Dr. Abdelsalam. I discussed your profile and welcomed you formally before, but it's great to have you with this great panel.
Thank you. I apologize. I was stuck in the case and it took longer than I expected, so I apologize.
We figured you guys are pretty busy, so we're just blessed to have you. This is a question I get all the time, and I'll start with Dr. Cotta, but anybody can answer. So I'm seeing my urologist. I had kidney cancer. When's the right time to get a referral to an oncologist? And I'll even add on to that, even a nephrologist.
Sure. Is the scenario you have a renal mass?
Yeah, I have renal cell carcinoma. I'm not really, I mean, you're probably going to talk about size and location again, but a lot of people are not sure when to see an oncologist after they have surgery or even before they have surgery. If it's stage 4, it's obvious, right? We get that referral, but what about the earlier stages? And what's your
so being an MD Anderson, we are a tertiary care center. We see a lot of new patients, but we also see a lot of second opinion patients. And I think if you're considering having surgery with a general urologist locally, you would definitely want to know partial nephrectomy. Some are relatively straightforward, but they also are risky. You're cutting into the kidney and you're manipulating the blood vessels to the kidney. But sometimes if it doesn't go well, there could be such as tumor spillage or even a conversion to a radical nephrectomy. So those are very real considerations. So I'd want to make sure my surgeon is comfortable and has a high volume of partial nephrectomies. They're not doing just a few per year, that whether they do open or robotic, they are comfortable with either one. And if there's any hesitation, just get a second opinion. There's people who've done the SUO fellowships, Society of Urologic Oncology fellowships, or we love doing those cases and seeing second opinions and doing anything that may seem complex or out of the ordinary for the general urologist. And I've had many patients, and it's my favorite thing that I get to do is see a patient who had been counseled on getting a radical nephrectomy, and then I'm able to do the partial nephrectomy. And that's really rewarding for the patient and myself.
But you segued into my next question because it's one that always gets asked is when's the right time to get a second opinion? Or my favorite is I love my doctor. I don't want to upset him or her by getting a second opinion. This one's open to anybody to talk about, but there's a reluctance to get a second opinion because they find they might offend the doctor that they have.
Sure. I think most doctors are actually not offended by that. And you just want your patient to feel comfortable with what care that they are getting, whether they come back to you because doctors who they saw said, yeah, what you're doing, your plan is perfect. So I'm going to stick with you, or if not, they feel comfortable elsewhere. We see so many patients, so I don't think they would get offended.
Dr. Msaouel got a great question for you. What about chromophobe Burkhardt-Dube syndrome or somatic?
Germline. Burkhardt-Dube is germline. Chromophobe can be associated with obviously somatic mutations, but Burkhardt-Dube is a syndrome, a genetic syndrome associated with germline mutations in a gene known as follicular, FLCF. So it's definitely germline.
Got you. Dr. Abdelsalam, we talked about ablation a little bit earlier, but you're probably the most expert in this one. Can you talk about ablations, the pros and cons, and what's the decision-making process to have an ablation done?
Very sure. And at MD Anderson, we have very good collaborative of efforts, as you see, among different specialties for the best patient's interest. So usually when the patient presents with a small renal mass, they show up in the urologic clinic. Dr. Cotta is one of only 3 kidney urology surgeons. They evaluate the patients and they discuss with them the treatment options. Since 2017, American Urological Association has included ablation as one of the treatment options for lesions up to 3 centimeter, and the NCC and guidelines go up to a T1E, like 4 centimeter lesions. Patients with comorbidities or patients that are not wanting surgery, or patients who are anxious but they do not want to be watching this mass, they usually ask for some kind of intervention. Ablation has a happy medium where you do something for the tumor, you treat the tumor. At the same time, it is not affecting you significantly in terms of what we call perioperative outcome. Does not require much before the procedure, does not require much after the procedure. Usually, patients go back to normal activity within 48 hours, maybe heavy weightlifting in 1 week or so. Patients are usually back really quick to their normal activities. The whole concept of ablation is we basically apply a direct energy to the tumor to destroy its cells. And this can happen through freezing or through burning, through heat. There are different modalities, but the concept is general, either heat or freeze to destroy the tumor cells. And the results are really very good. We are talking in our institution, we are talking about 95 to 97% complete treatment from one session. Patients usually all the time are usually on their stomach lying. We do some imaging for planning purposes. They are asleep under general anesthesia 100% of the time. Then according to the size and the location, we decide how many, what we call probes. Basically, those are the needles that we place, and we deliver the energy.
Doctor, I've had the freezing ablation and it was pretty much painless, and I'm thankful they put me to sleep. But how do you determine freezing versus heat? That's a question that often comes up.
Yes, it does. It's a technical thing. Basically, in general, let's say in general, all of them are good. And the best one for the patient is what is the intervention, the radiologist is most knowledgeable. However, at Anderson, because we have all the options, we try to have some selection criteria based on the location and the size, which modality we use. So usually those are the 2 big guidelines, like big 2 points, key points, which modality. However, there are a lot of institutions that they use only one if they are more comfortable with. sometimes it is the only thing that is available, still have good results. As I said, we have about 97% with heating, and we usually those for the smaller lesions, and about 95% with the freezing one. And we usually keep those for the larger.
Thank you. Liza, I'm not ignoring you. I want to save that question for the end, but Marlene asked a question that Dr. Msaouel, I think, is best to answer. The subtype papillary, which we don't talk about or haven't talked a lot about, is the second most common type, but there is not much information or research. Why is it that, oops, the question just moved. Why is it that stage 3A, grade 3, type 2, size 2.4 centimeter with partial invaded the fat, so graded to 3 after partial? Is there new research being done on this subtype?
Yeah, and that's, as you said, this is a question near and dear to my heart. There is some sociology in that, in the sense that there is this idea in the medical world that the only way to move forward with developing very reliable clinical data and guidelines is by doing big randomized trials. And the more rare a cancer is, the much more difficult it becomes to do that. And of course, the more rare a cancer is, the less financial support there is, the less interest there is to address it, et cetera, et cetera. So there are a lot of challenges. If anything, we've shown with renal medullary carcinoma, which is far more rare than papillary or chromophobe, for example, that we didn't need to do these randomized trials in order to move the field forward. We actually developed targeted therapeutics for systemic therapies, or with Dr. Tang, we incorporated radiation therapy to the management of patients with renal medullary carcinoma and changed the practice and showed that it's feasible. Our colleagues at the NCI have done similar things with HLRCC and FH deficient RCC. And I think that this is showing to the community, including our patients and our patient advocates, that no, we can do much better with regards to the non-clear cell subtypes. And it is actually extremely encouraging for me to see how much the patient advocates, through their organization in their recent years, by supporting small but meaningful grants and funding, are now accelerating research across the subtypes, including chromophobe, including translocation kidney cancer, and others. It's very exciting. I know that in the coming years, there will be dedicated clinical trials, biology-driven, for these subtypes that otherwise wouldn't exist. Now, for papillary, there is one more nuance that sometimes we're learning as the years go by, that term is a little bit of a general term. What 15 years ago we would have called papillary, now we may call FH deficient renal cell carcinoma, or even the TFE3 or TFE beta translocation renal cell carcinoma we used to call papillary, or the ALK mutated kidney cancer we used to call papillary. So that's part of the challenge as well, that papillary is a more broad term that encompasses a lot of different subtypes. So with papillary, there are two strategies. It's common enough that some randomized trials have been done, spearheaded by one of our colleagues at City of Hope, Monty Powell, some very nice randomized trials, but at the same time, it has these molecular distinctions that allow us to go deeper into the biology, as I implied, and do the kind of approaches that we did with renal medullary carcinoma, et cetera. So stay tuned. There's a lot of exciting stuff in that space.
Thank you. I am not ignoring the questions. I just want to go back to our questions we had, and we will hopefully have time at the end, and some of these will be answered just based on what we have going on in the future. I want to move on to adjuvant therapy for stage 3 RCC. It's a relatively new, at least 4 or 5 years ago when I was first diagnosed with stage 4, I really never heard of adjuvant therapy for stage 3 RCC. Dr. Msaouel, how's the decision made to use Keytruda with stage 3 after a nephrectomy?
Yeah, and it's definitely exciting that we have an adjuvant immunotherapy, pembrolizumab, trade name being Keytruda, for kidney cancer. And that applies to any adjuvant therapy across cancer. The way we decide whether to give it or not depends on the risk of the patient to have their cancer coming back. Because why would the cancer come back? It would come back because it's still in their body. And what happens is that, when we do imaging with the CT scans we have now, let's say we can detect things that are 1 millimeter in size, which is very small, tiny, but the cancer cells themselves are so very small that you actually need to have millions of cancer cells there to get to 1 millimeter in size. So you can have hundreds or even thousands of cancer cells anywhere in your body and we cannot see them. Or you may not, like we don't know. And when we are in that situation where you may or may not still have cancer, that's the adjuvant scenario where we might either choose surveillance to keep looking, or we might choose to use a systemic therapy like pembrolizumab. Now, the problem is that if we give adjuvant pembrolizumab without knowing whether you have the cancer or not, we're exposing patients to the side effects. And sometimes, very rarely, but it can happen, they can even be lethal. They can even cause permanent damage. And to cause permanent damage to somebody who doesn't have cancer at all, because we don't know, you got to think very carefully. And so the decision making is based on how much do we think the risk is of the cancer coming back. The higher the risk, the more the benefit. And there are risk calculators, and Katie Coleman, one of our patient advocates that some of you know very well, has even adapted one of the ways that we use to estimate the risk reduction by adjuvant pembrolizumab to a very easy calculator that, in fact, many of our faculty use as well. And so you can use the nomograms that our urology colleagues have spent decades creating to estimate the risk. And then you can use that calculator to make some inferences about how much would your benefit be in reducing your risk of a cancer coming back at 2 years, 3 years, 4 years, etc. When you make these calculations, you may find out that your benefit may be smaller than you think. And that is why it's so very important to make such estimations.
Yeah, first of all, Katie is amazing and a friend of mine. The next question, I'm assuming based on what you just said, I know the answer, but do specific features like sarcomatoid and rhabdoid impact the decision to?
Yeah. Again, this is the thing. The beauty is that once you start putting everything together, you fit the pieces and you're yourself a kidney cancer expert. So you know the answer. When you have a sarcomatoid or rhabdoid change, which increases your risk of the cancer coming back, your absolute benefit can increase. At the same time, though, it never is that easy, because if sometimes we may decide that your risk of your kidney cancer is so high of it coming back that it might be better, instead of starting with one therapy like pembrolizumab alone, to wait until the cancer fully declares itself and give it the full force of 2 drugs together, or even enroll in a trial that may be exploring more drugs in the hopes of eradicating all of the cancer. So that's why it's always important to individualize our strategy.
So I do not know the answer. I don't know what answer you're going to give me on this question, but it just came up. Where does the use of biomarkers like a Signatera and Natera come into the equation as we figure this out?
Yeah, so this is an exciting time, and I think that this is a good one for Dr. Chad Tang to discuss, because in the same way that with renal medullary carcinoma, we've established and people are using in 60% of patients, we use CA-125, a blood biomarker. Dr. Tang presented in one of our major cancer meetings, the ACR meeting a few weeks ago, that there is a ctDNA assay that we've established with Myriad that appears to be reliable for clear cell kidney cancer. So one of the challenges, believe it or not, with clear cell kidney cancer is that out of all the common solid tumors like prostate cancer, breast cancer, bladder cancer, etc., it's the toughest one to detect in the blood. The only one tougher is glioblastoma, which is a purely brain tumor. It doesn't go in the blood. So for whatever reason, clear cell kidney cancer is very difficult to detect in the blood. However, the beauty is, stay tuned. That's the beauty of research. Now there are the ctDNA approaches like what we presented with Dr. Tang, and other biomarkers like KIM1 is one I know you guys have been hearing about that hopefully will change this. However, I also want to point out this is all still research. We're all very excited, but until we understand how exactly to use them, be very careful with them. I have seen a patient, for example, that was having one of the ctDNA assays, a little bit of an older version of it. I mentioned where it was literally going down. And that's one example that comes to mind. The patient was developing cord compression. That's a catastrophic event. Why that was happening. This was a couple of years ago. I believe we're getting better at it, but it just shows you how you have to be careful. This is still under research.
Dr. Tang, would you like to add?
Yeah, so I think it's really an exciting time for circulating tumor DNA and these biomarkers. The newer generation of an assay, like the myriad assay, we call them second generation assays. So let's take compare like we call first generation assay. It sequences your tumor and it finds 16 different sites that are in your tumor, but not inside your normal blood. The newer generation sequences much more of your tumor, the whole genome, as in just the parts that protein, and it finds up to 2,000 rows to look. So you get a higher sensitivity to look for even smaller amounts of DNA specific to your kidney cancer in your blood. And we think that's especially important, as Dr. Msaouel mentioned, in kidney cancer, because it's a low shedding tumor. And then especially if you have localized kidney cancer, the chances are even less that you'll be shedding. So you're finding probably 100x less, 2 orders of magnitude less, in theory, with these newer assays. You couldn't, in theory, with the first generation assay. But still, like Dr. Msaouel mentions, it's a lot of data right now, a lot of interesting times, but none of it's ready for prime time quite yet.
For whatever it's worth, I've had Signatera every month since day one, and it's tracked my progression every time, which is interesting, right? I know that doesn't happen all the time, but it's been an interesting test. I use it as a tool. I think what I would tell patients, don't ever make that the determiner of what you do next, but use it as a tool of many. Okay. We're going to move on to a topic that gets a lot of discussion in the KCA Facebook community, biopsies. So we still have people posting that biopsies spread cancer. There's a high risk of leakage. Never, ever have one. So I'm going to turn this over to Dr. Abdelsalam. When are biopsies warranted for stage or for renal cell carcinoma? And please address the issue of leakage that Sid and me and others are combating every day with a community that doesn't want to believe that it's overall relatively safe.
Sure. Let's talk about the biopsy itself. So the biopsy itself is a very safe procedure. I think there is a lot of misconception around, misunderstanding. We do about 500 biopsies a year, and we published on renal biopsy for kidney biopsy under MRI guidance. This study included 150 patients. I'm working on another study right now, which included 1,000 patients. This is all incorrect information. First of all, the complication rate is really low. The most common complication in general is bleeding. And most of the time when it happens, we just watch it. We do not have to do anything about it. Very small percentage that we need to go there and basically block the bleeding vessel. Regarding the leakage, I have never seen a single case of leakage after a biopsy. I have seen very few after ablation, but we're talking about like handful over like 15 years or so. I never seen a tumor seeding, like the spreading the tumor. The new techniques that we use, basically coaxial technique, where we have a needle in there, and through this needle, we go and take samples with another needle. In my study, there is no single case of tumor seeding. In the 1,000 patients, there is no single case of tumor seeding. In the American Urological Association guidelines, it was correctly stating that in the modern era, there is no single case of tumors. So I think it's all misconception. Definitely, there are some risk factors that may make the procedure has like a higher risk. For example, patients on blood thinner, aspirin, those patients by nature has a high risk of bleed. And when it comes to kidney or liver, like some vascular organ, yes, there's a higher risk. But overall, the biopsy is very safe procedure. We do it all the time.
So we have, I don't think anybody here would disagree. We have 4 doctors from MD Anderson that are telling patients that if done by a skilled doctor with the right instruments, it's a safe procedure and bleeding.
Very safe.
So Sid and others on the KCA Facebook community continue to dispel those myths. We literally have people say, my doctor will never give one. And I explain, like, for stage 4 patients, we need that biopsy to help determine the treatment because we're not having our kidney taken out in many cases.
Correct. And this is what brings us to what Rota said earlier. You have to go to the most expert when it comes to things like that, because not only the science or the knowledge, but also the experience and the number of cases that you have done makes a huge.
Okay, great.
And in our study, this was like the biopsy was diagnostic in 96% of the time. So
They're very helpful. On the scanning issue, really for our radiologists and anybody else that wants to answer, this is a very common question. A couple things. We hear PET scans are no good for RCC. I just had one today that showed my progression better than any other test. What's the gold standard for looking for kidney cancer as well as progression? And explain the differences between PET scan, MRIs, and CT scans.
So it depends on what stage you are looking. Dr. Msaouel can talk better about stage 3 and stage 4, but when we're talking about early stages, and MRI are very good and very effective in evaluating the tumor, the mass. He basically uses radiation to do imaging, and MRI uses waves to deliver and receive to get the images. Everyone has pros and cons, but in general, CT is really quick. And MRI requires longer time and requires patients to be really steady for a long time, which sometimes is difficult for some patients. Also, you have different contrast for T compared to MRI. For example, the patient that may have iodine contrast allergy, they may not be able to do CT, and in this case, we do MRI for them. MRI has better tissue characterization. For example, if it is a cystic mass and has some kind of concern about soft tissue nodules and things like that, MRI would be better to characterize the tissue and the nature. Definitely, MRI is more expensive. The American Urological Association does not differentiate between both of them. They call it a cross-sectional imaging before and after the procedure. So it depends mostly on the patient, every patient in terms of all the factors included. But we most of the time do CT pre and post, and this is more than that. CT uses a different dye where it depends on the functionality of the organs and the tumor, and it helps. But Dr. Msaouel can talk more about stage 3 and stage.
Could I just add something about PET CT to your question, Joel? Specifically with PET CTs, it makes your things that are active glow, but also it makes your urine glow.
Yep.
So something to note about stage 1 to 3 kidney cancers, when you're specifically the kidney, it's just glowing in the urine. Sometimes it's really hard to tell what's kidney cancer versus what's just normal urine.
Yeah.
So so maybe in the metastatic setting, in some patients who you could find some ability in different sites with this urine, but where there's urine, it's a little harder sometimes to see what's happening.
And Dr. Tang, I've heard it, Abdelsalam, I've heard that in Europe, there's trials on a specific PET scan tracer for kidney cancer. Have you heard about that?
In the US, actually.
Okay.
So it's called giretuximab. It targets something called CA9, which is found on kidney cancers and other things too. But it's supposedly helpful, especially in the localized setting. That's where the most robust data is. And I think you will be seeing it in a lot of other centers of trial very soon.
Also, they are working on some MRI imaging studies to try to get all the information needed with experiences from MRI rather than doing a biopsy. Still early stages, but also, as Dr. Tang said, it's pros.
Okay.
Just one thing I want to mention about the biopsies. So the biopsies are usually done when it will influence the decision making. For example, if it's a young patient that is not accepting anything except that he has to take this out, there is no need to do a biopsy because he already made the decision. If it is an older patient that nothing we're going to do about it, like really, we cannot do anything for him. So again, it is not affecting the decision. If we are going with active surveillance, if we're going with ablation, thermal ablation, than having an immunotherapy or radiation. Having a biopsy before that is very, very helpful.
My friend Michelle asked a question when we were talking about the PET scan tracer. Is that the ZINCON study that you guys were alluding to? Or is it a different study?
Yeah, and the Zircon study is the one. Yeah.
Thanks, Michelle. A question just Madeline asked, Dr. Abdelsalam, after listening to you, do I understand that MRIs with contrast is just as good for finding METs as CT with contrast?
Again, it depends. We're talking about the tumor in the kidney. So in general, MRI is more sensitive and able to better characterize the tissue. So again, if we do not usually start with the MRI, we usually start with CT. And if we have some challenges with the interpretation, we do MRI. But definitely MRI has a higher sensitivity. It can help to characterize the tissue inside the kidney and outside the kidney.
Views on, I have my bias, but you guys are the experts, views on contrast versus no contrast for CT scans. And there's a lot of doctors out there that when you don't have a kidney, won't do contrast regardless of your creatinine or EGFR. And I think you may have a different view of contrast for scans.
Okay, so the non-contrast versus contrast CT, it depends on what you are looking for.
Yeah.
So if you, for example, looking for a stone, non-contrast CT is in it. But if you have a mass, you definitely need a contrast CT. We start with the non-contrast CT to know what is the baseline of this mass, how it looks like. And then we did a contrast study and we take pictures in different phases to characterize it. So see how it enhances, how it washes out, how it looks in the delayed phase. For any patient with a mass, we need a contrast. Non-contrast study is not helpful. If the patient has some contrast allergy or we are concerned about the kidney functions, then the MRI is considered a good alternative where we can still do it with contrast. But as I said, it may have some challenges in terms of how long it will take and how comfortable the patient.
And just for the patients out there, when I get contrast with my one kidney and relatively high creatinine, I get hydrated IV before and after, and my scores have personally never been impacted by the use of contrast for CT scans.
Right.
I just think that patients need to ask the doctors and challenge them and talk about the cons.
I think now there's more tolerance with the newer contrast agents, and the more knowledge we know about it, and we can. In the past, we used to have higher limits where we do not inject contrast. Now this level is going less and less. Pretty much any patient with a GFR more than 30 ml can get contrast. But as you said, some of these we need to do some preparations with IV fluids before and after.
Great.
Also, the medications can affect the excretion. So it has to be personalized based on the patient.
Very helpful. Dr. Cotta, we're going to talk about cysts. When do they become neoplasms and how should we stay vigilant for innocent looking cysts? And you probably want to talk about the Bosniak scale as well. So all yours.
Sure. Yes. So when I see a simple renal cyst, the radiologists are usually very good at doing the Bosniak scoring or saying this is a simple cyst. I tell patients that this is benign. It's not cancer and it doesn't turn into cancer. We don't need to watch it. I try to be very definitive about that to ease anxiety. And then we look at septations or nodule. Septations can increase the complexity of the cyst. So that's just essentially like a thin band or a line that we see going across the cyst. Usually those are still benign. The thing that we really care about is nodules. So some cystic renal cell carcinomas can have fluid around them, but there has to be a nodule, a solid nodule within that. But even if it is an RCC, a cystic RCC, those tend to be less aggressive. So sometimes we'll watch them. And if the nodule grows, then we can consider our treatments for localized renal cell.
Yeah, protocol for keep an eye on it. Is it ultrasound or scans or what is it?
Yes, MRIs are usually pretty good at looking at cysts. It's really helpful because sometimes cysts you want to look at the density if it's enhancing or not enhancing. And sometimes cysts can be hemorrhagic and that would be benign, but also sometimes they look like a papillary renal cell carcinoma. So MRI can be really helpful in that instance. But yeah, mostly every 6 months, MRI potentially, sometimes CT. If it's been stable for quite a while, you can do an ultrasound as well. Just take it a case-by-case basis.
Very helpful. A lot of people are always looking for statistics for recurrence for stages 1 through 3. Is there a best place to get the most up-to-date current statistics rather than going on the internet and Googling it? And really this is for Dr. Msaouel and Dr. Cotta, at a high level, can you give statistics for recurrence? And I know it depends on lots of different factors, but patients ask that question all the time.
Yeah.
Dr. Msaouel?
I think this is a good one for Dr. Cotta as well. You can either use the general numbers of how likely it is if you have stage 1, stage 2, or stage 3. But I actually think that, and obviously the higher the stage, the more likely it is to recur per year. But I actually think that we can be much more robust than this. We can be much more detailed by thinking all the different variables beyond just the stage. Things like, as you said, does it have sarcomatoid differentiation? What type of kidney cancer this is? Again, a renal medullary carcinoma has way more chances of coming back than a clear cell. Or let's say you take a chromophobe kidney cancer. A chromophobe kidney cancer in general is not very likely to come back unless, for example, it has sarcomatoid changes. If it has these features and some other features we're learning, like tumor necrosis, etc., then the chances of it coming back increase. Our urology colleagues have been doing a very careful job trying to come up with these nomograms and prognostic tools to be able to exactly refine the recurrence risk estimations that then help us, again, think about things like adjuvant therapies, etc.
Dr. Cotta, anything to add?
I agree. We have nomograms, and I do tell patients that our recurrence estimate that we can give you, a number, is based on pooled data from thousands of patients. So it doesn't include your data, just it's what we think based on our experience and history and looking at many patients in the past. So I just try to give them that caveat that we can't, this is a prediction, but it's not a certainty in any sense.
Thinking of data not on the list of questions, surprise for all of you. Can you talk about AI and what's it doing with respect to kidney cancer, whether it's prognosticating or helping doctors get better information? Because I assume this is a huge area for all of you, especially at MD Anderson. Anyone?
Yeah, I would say I discuss my lab's experiments with AI almost every day now. And in fact, we used to, in my lab meetings on a weekly basis, to have use case scenarios, how we can use AI to improve our research. We don't do it anymore because I think that my team has become better than me at this. And it has. For example, some things, it's like eyeglasses. You know what I'm saying? These are things that augment you. They don't replace you. This is technology that can really augment what you're doing. For example, for some people for whom English is not their first language, it has dramatically improved their ability to write manuscripts, write grant applications, do things like that dramatically, even structure their thoughts. It can replace in some ways Google. The Google search now, you can use AI. It thinks. It may not necessarily have consciousness, but it is intelligent in some ways and dumb on others. It can hallucinate. So knowing its strengths and limitations is absolutely key. And depending on the AI. So there's all these different types, and there are articles about some of them versus others. Can it help with prognostication? Yeah, there was a fantastic group study, for example, just published by UT Southwestern in Nature Communications on using deep learning, the skeleton of a lot of AI, to analyze pathology. And that can be used, let's say, to forecast potential response to systemic therapies, etc. Here's the trick, and this is something not just for patients, it's also for faculty and fellows, etc. AI and those types of approaches are very useful in situations where you have very high, we call it signal to noise ratio. That applies whether you're an engineer or whatnot. And so things like pathology, slides, and radiology, they have a very high signal to noise ratio. When you look at something, that's what it is. So it's easier for the AI to absorb that information and come up with useful inferences. When you become much, much more probabilistic, what Dr. Cotta implied, you may have 100 cases and X happens. And then you may have 100 cases which are supposedly the exact same and the opposite happens. Completely probabilistic. That's where AI stumbles. Like it's not as easy for it. And so a lot of the decision making that patients want is probabilistic. And that's where AI is not ready to replace humans just yet. But it can certainly augment us, and it does.
The movie Terminator scares me a lot more today than it did when it was first on. And great response. Dr. Tang, I had my nephrectomy. I consider myself cured. Forget the medical definition of that, but I'm done. What's the standard protocol? And I guess this is for Dr. Cotta as well, with respect to how often do I get scans? What type of scans? How often do I see my urologist? When do I call you guys if something's not right? Love you guys to talk about that a little bit. We'll start with Dr. Tang and then go to Dr. Cotta.
Yeah, sure. So I think generally you want some sort of imaging of the abdomen every 6 months to 1 year, depending on what your stage is, and all 1 to 3. That depends, as we discussed, on your renal function and whether you need contrast or not. You want to include the chest probably every year as well, also depending on what stage you are in. And you also want to be making sure you check your general labs. Important things like kidney function are important to measure and keep track of long term as well. Where you probably want to see us or come to the end is when you are worried about recurrence. And that could take on a couple different levels. A growing nodule that needs a biopsy, or something that's already been biopsied and found to be recurrence or metastatic kidney cancer. Those would be something that we would involve Pavlos and his colleagues to get to as a first one. And then after that, yeah.
Very helpful. Dr. Cotta, anything to add?
Yeah, I agree. And I agree with what Dr. Tang said. If there's anything out of the ordinary that needs to be evaluated, you can have recurrence even locally. If you've had a partial nephrectomy, you can have small nodules that can grow in the retroperitoneum. That's maybe not even metastatic disease. Yeah, anything out of the ordinary, definitely get us involved, but keep up with surveillance. And surveillance can be anywhere between every 3 years to up to 5 years, depending on your stage and at diagnosis and pathology, final pathologic staging.
So I have blood in my urine. Do I just say it's just a bad day and wait 3 months, or do I call you guys?
Yeah, you can go ahead and give us a call probably.
You would be surprised.
Yeah, bone pain.
Yeah, back pain. Yeah. Somebody asked a question, so it relates to what we're talking about. And I'm assuming this relates to not treatment, but the actual renal cell carcinoma. Why does it cause such havoc on our bodies? Fatigue, high blood pressure, weight gain, night sweats, skin issues. Dr. Cotta, I'll start with you.
Well, that would be a good one for Dr. Msaouel as well. But even when I see patients that have a large renal mass that's localized, so maybe stage 3, they do have those constitutional symptoms and a lot of anemia as well. A lot of times they're very fatigued. And even if they're not bleeding from the renal mass is so vascular, it creates a lot of collateral blood vessels. So taking it out, you can have multiple sort of units of blood just in the renal mass itself. It's really dramatic. And I also think the RCC is highly immune infiltrated. So your immune system spends a lot of time trying to attack it. And that's where you get a lot of those symptoms.
Dr. Msaouel, anything to add?
Yeah, and a lot of the symptoms mentioned in that question, high blood pressure, skin issues, and fatigue actually are from the therapies, or can be from the therapies, like the targeted agents that we give, the pills. Sometimes patients call them the chemo pills. They can increase your blood pressure. They can give you skin rash. They can certainly give you fatigue, etc. So that can be one. It's not the cancer itself, it's the therapies. The other scenario is indeed that 2 things. One, the mere fact that you get all these cancer cells dividing in your body, they need resources in order to divide. And so they can take your resources. So the energy and the glucose, etc., that you would want to be using for your cells, they take it. And now you don't have those supplies, those nutrients, you feel more fatigued and weak. The other thing that they can do is they can actually secrete. They produce and secrete proteins, like cytokines is one of them that we call. And these proteins, they go around your body and they can cause fever, or they can change. Some of them can be even hormones that they can affect things like your blood pressure, the amount of blood you have in your body, etc. So those are some of the key mechanisms that can cause this, what we call constitutional symptoms.
Very helpful. And while the doctors may not focus on this rightly, I will tell people that there's a mental side of it. This is cancer in our bodies, and it's amazing how our mental state can impact us physically. So I always tell people getting help is a badge of strength, not a weakness. And I think most of us need it when we have this disease. Okay, so I have stage 3 cancer. I have sarcomatoid features. I've been told it's going to the tumor board. Very few people really understand what a tumor board is and how does it function and what the benefits are. Again, not being personal, I just had the tumor board at Northwestern report back to me today. So I'd love anybody just to talk about what is the MD Anderson tumor board? How does it work? When is it engaged and what are the benefits?
You have the tumor board with you right now.
Okay, so who's
So this is what the tumor board is.
Okay, so how often do you meet? What cases are discussed? Who presents at those cases? Do you have the residents? Just tell us about it. It's mysterious to us.
So I can start and then everyone can turn it. Basically, but the tumor board is basically we have all the specialties that are addressing the same disease. They have a meeting. We do it at Anderson once a week. So you would have medical oncology, you would have surgeons, you would have radiation oncology, you would have interventional radiology, and you would have pathologists and radiologists to review the images. And basically, any physician from this group that has a case that want to present in the tumor board and discuss and get different opinions from different specialties, they put it on the schedule. Sometimes the trainees present, and sometimes the primary physician presents the cases, and we got all different perspectives from different specialties, and then we come up with the best for the patient.
It's fascinating. So the thing that we need to know as patients is when it goes to the tumor board, we're getting a multidisciplinary approach and a response to what's best for us.
Correct.
That's fantastic. Good. Another topic that gets asked about all the time is genetic testing worth it? And we've heard things like if you're over a certain age, don't do it. If you're under a certain age. Dr. Msaouel, I'll start with you and anybody else that wants to answer that question.
Yeah, and again, it goes to the decision that we made. There are 2 types of genetic testings, and that's important for patients to understand. One of them looks for the germline mutations. The other one looks for the somatic mutations. And so if you're developing at a young age a kidney cancer that is known to be associated with a germline syndrome, let's say Berholt-Dubé mentioned in the chat, then you can do a germline testing. And why do you do that? Because if you find that indeed you have this syndrome, first of all, that plays a role in how we screen you for other tumors or other diseases associated with that syndrome. And also it's important for your family to know because they might need also tested. So that's one scenario. The other scenario is the genetic testing for somatic mutations. Those are the mutations only in the cancer cells. So in that case, we analyze the cancer. So that's the difference. When we do the germline one, we might take a swab of saliva or we might take a blood sample because we look for your normal cells. But when we look for somatic mutations, we use the cancer tissue that we have from a biopsy or from surgery, etc. And we use that control as the comparator, potentially your saliva or your blood. But we're not interested in the saliva or the blood. We're interested actually in the tumors. And that can be helpful because sometimes knowing the somatic mutations as well can give us an idea about prognosis. So for example, we know that even in clear cell kidney cancer, if you have a certain mutation, BAP1, it tends to be a more angry cancer than if you have, let's say, just PBRM1 mutation. It gets more complicated that I'm being very roughly speaking, but even that is information, and knowing the prognosis can be helpful both for patients and physicians. In other cases, it can even guide whether you're going to use therapies. So for example, if you have something called the ALK mutation, you might give drugs targeting ALK for certain types of, we used to think they were papillary, many of them. And that's something we're actually investigating whether or not using such drugs is helpful. So stay tuned on that. Or it may help enroll in clinical trials that target specific mutations. So that can be valuable, all of this information that can guide management. So that's why physicians might recommend that you do it.
Very helpful. I'm going to take advantage of it quickly. Probiotics and the impact on immunotherapy.
Yeah, so there is zero doubt that the interaction with what we call the microbiome, which is the microbes, not just bacteria, but everything that, is in our body, and health is important. There's no doubt. Same as with metabolism. And that will cover also potentially your metabolism/diet questions. The same thing. The very complex system, a very complex interplay that we know is important. We just don't know how to control. So you may think that if I do X, I am going to get a benefit, but actually maybe 10 or 20 years from now, when we get smarter, we may realize that, oops, it was actually the opposite. So that's why we wouldn't recommend probiotics, for example, or specific diets or whatnot, specifically to treat your cancer. We might recommend them because sometimes patients may find the probiotics, let's say, for example, useful to address certain side effects. And sometimes there are some patients that will swear by certain probiotics or Greek yogurt or whatnot with PKI, chemo pill side effects, and some other patients that just don't like them. The same goes with some diets that some patients really, they can do it, and some patients will hate them. It becomes counterproductive if you do something that you hate, because if you don't like the food you're getting, then you're going to lose calories. And already the therapies we give make you lose calories, and then it becomes counterproductive. So don't try these complex strategies because you think that it will really affect the therapies. I wish we were certain about that and we knew, but you can certainly take advantage of them if they help you over.
Great answer. And by the way, we have a separate panel on that coming up in June. So I'm going to listen in on that one. And by the way, I do love the diet of moderate. Eat more chicken, fish, veggies, and fruit. Eat less processed foods, red meat, alcohol, sugar. But if I want that piece of pecan pie and steak, I'm having it. Thank you. You just confirmed it. I'm going to go back to some questions. And guys, if you have questions, just put them on the right side. And we will get to that question. That's going to be fascinating to see how you guys answer it. This one's from Robin. I had a left partial nephrectomy October 21st, 3.2 centimeter grade 1, stage 1. That's good. Ned since then, thank goodness. I'm getting surveillance with chest x-rays and MRIs of the abdomen. But my question is, I want a CT scan of my lungs yearly. I'm 48. My doctor states it's just not necessary. I'm young, and he'll give me cancer looking for kidney. And he'll basically issues, I want my lung scans yearly, and I don't think there's any indications to have it, but I'm interested from the radiologist. What do you guys think? And Dr. Start with you.
Yeah, sure. Basically, we do not do lung as a standard of care. We do chest x-ray. The CT, by nature, the T1A, he said it was about 3 centimeter lesion, 3.2. They have very low metastatic risk, and a lot of studies out there has shown that those patient population did not develop even metastasis. The studies that have shown metastasis showed very small percent of patients. Cost benefit, we cannot be doing CT lung for every patient because we would not be benefiting from it. At the same time, we're overwhelming the whole medical system with a huge cost. So I totally understand he needs peace of mind because CT is going to make him see really everything. But again, in medicine, we're talking about science and the most effective thing that we can do for mass population. And that's why in chest x-ray, we do not do CT.
Good. Okay, here's the question. Let's try to stay apolitical, but I know it's near and dear to everybody here that's involved in research. Can you talk about how the cuts to kidney cancer research through the Department of Defense are impacting current research? Is it impacting you guys specifically day to day? Dr. Msaouel, we'll start with you, but anybody can answer that question.
Yeah, thank you for asking this. It does really matter to everyone living with or at risk for a kidney cancer. And there has been cuts. It is well known that last year and the years before, and the Congress through the Department of Defense allocated $50 million for kidney cancer research exclusively. And this year it's zero. So we went from 50 million to zero. And then there is also the proposed budget cuts to the NIH by something like 40%, which is also going to affect, obviously, kidney cancer research, some other things. That financial support is important because, for example, the kidney cancer research program by the DoD that's now been cut completely is a unique engine, especially for early stage, high risk ideas. It's the kind of things that you want. Let's say for the papillary question that was asked, it was the second or third mechanism to support our RMC research when it was very crucial. Otherwise, it might have died off. And all of the RMC stuff that you guys are hearing about may never have. It's also, this research is important because when we lose it, this also creates talent bottlenecks because you want these junior faculty, junior investigators to get invested in kidney cancer. For that, they need support. And if they lose the support, they get discouraged. Again, I was being told that focusing on RMC at the time was the equivalent of career suicide. And it becomes harder, it becomes easier to advocate that it is a career suicide when there is no. And it has this ripple effect on collaborations as well. There were multi-site studies that are relying on this team science mechanism. A lot of this DoD and the NIH are supporting the team science. So it's a challenge. We deal with this every single day, including today. But despite that, our teams, I think, do show up every day, determined to keep our pipeline moving, determined to keep the momentum. We tighten our budgets. We share core time facilities. We lean on philanthropic partners to bridge gaps. And the science continues just with more friction. I think that kidney cancer doesn't care about political affiliation. And historically, the KCRP, the DoD program, has enjoyed support from both sides of the aisle. And it is because it pairs fiscal and financial responsibility with tangible returns. And I think that when this was cut, I think people didn't realize what they were cutting in Congress. So I think that one of the things that we can do is really share our stories, both the researchers and the patients. Share your story with your representatives so that they know that these are real people, constituents that are affected by this, can join advocacy groups, spread the word on social media, etc. So that, yes, the cuts are creating daily challenges and hopefully we can push back. They have galvanized us at the same time to streamline our experiments and advocate together and across party lines. And that's what we want to continue doing.
So there's a couple of things we patients and caregivers can do. Number one, should not be a political issue. This is about our health and our lives. And I agree with you. Nobody really took the time to figure out the impact. And by the way, I'm a reviewer for the Department of Defense for kidney cancer research. And I fear that the people that did all the work on the DoD side are going to be fired and we're going to be years suffering from the lack of expertise in that area. But that concerns me. But number one, continue thinking about making donations to groups like the KCA that helps fund research and other organizations. Number two, Linda Anderson has put on the Judy Nicholson Foundation a really easy way to write your representatives. And literally it writes the letter for you based on the state you're in. And number three, get involved with, I think it's KC CAN and their advocacy efforts. And number four, share your stories. I think you're right, Dr. Msaouel. I wouldn't be here today, but for James Allison in your voice, all that he did. And I know the medullary cancer group that you work with, they depend on research, and God, what you've done the last 3 or 4 years is absolutely amazing. But we can't just be on the sidelines, like saying this is not an issue. This is real. And I've seen doctors tell me that basically some trials have been postponed or suspended at different hospitals that don't have the same philanthropic benefits that I think MD Anderson gets. So it's a great question. And again, don't make it political. My Facebook community has been engaged for 2 years and we don't allow politics. And it's amazing how that's, I think, saved our community, but it's not a political issue. I have a question for all of you guys, each of you, clinical trials that are out there. What excites you as it relates to stages 1 through 3? So I'll start with Dr. Cotta. Are there any clinical trials that you're involved in that are like exciting and that we should be looking forward to?
So the Zircon trial that was mentioned, that's something that we're a part of as a group or going to be. I think that's super interesting. And then as well as the biomarker research and trying to develop some biomarker informed clinical trials are things I'm excited about.
And does that include looking at also urine, using urine to get those biomarkers too? Are there trials in the works on that?
Trials, I'm not sure, but I know that and at least we do, and many centers are collecting urine as part of our research protocols. And if there is something that is discovered that is useful, that's definitely something that we would look at. But RCC comes from the cortex, so it's not much secreted in the urine, but it's something that we do collect.
Dr. Tang, what's exciting you on the clinical trial front?
Yeah, so a little bit more advanced in the more metastatic patients with with radiation. We're doing a lot of stuff looking at using radiation instead of therapy as a time to buy good quality of life time before you start on the drug therapy, and that pairs hand in hand with biomarkers. So we've had some really good success in there and that, and there's been a couple of big trials going on in that area as well. So not quite localized, but it's I think an exciting area where we can maybe buy some time before you have to use a therapy.
Dr. Abdelsalam?
Yeah, for interventional radiology, there are actually different things. So for patients with non-metastatic disease, there is MD Anderson is one among 10 sites in the U.S. where they have a registry for renal ablation, and they have almost 1,000 patients. So it will give us a lot of information regarding renal ablation, different modalities, outcomes, and quality of life as well as part of this registry. Also, there is a relatively new non-invasive machine that is maybe some patients are familiar with. The histotripsy is under research right now. Some studies are out there for the liver, but nothing for kidney yet. So this is research. It will be good. We have good promising results. But I know sometimes there is information around about things like that sometimes would mislead the patients because it's very promising for any patient to have something not invasive. But unless we have enough evidence that this is as good as the existing treatment options, we cannot. Also, for the metastatic lesions, there are studies, local therapy with immunotherapy, as Dr. Tang has mentioned, also metastatic disease, the impact for those patients on these patients in terms of sometimes for palliation and sometimes for.
For the group, can you explain what oligoprogression is and oligometastatic?
Yeah. So patients with oligometastatic or oligoprogression means that a patient had a cancer and it went to different organs, but only few sites. Usually the definition goes less than five spots in the body, and it can be controlled by a local treatment. So this is where our radiation therapy.
How it relates to me and probably other people in the past, when we had those couple spots, they would switch treatments. Today, they will consider the treatment still working, and I call it the whack-a-mole. They whack the mole and keep you on the same treatment. And I'm thankful for that. That's not a term I heard of 4 years ago, and I hear it a lot today.
Right. And also sometimes it helps when sometimes patients respond really well to systemic therapy, but maybe one or two lesions are not really responding proportionately or actually not responding at all. And then this is again when radiation and interventional radiology can intervene locally to address this one or two spots.
Great. Dr. Msaouel, as you answer the question, a lot of people got excited on this phase 1 cancer RCC vaccine study. And I tried to tell people that's extremely small group and a long way to go. Can you talk about the RCC vaccine trials and also some of the trials that you're interested in?
Yeah, I'm intrigued by the vaccine work, but I would like to see more data. I'm definitely very happy that people are exploring them. I think the technology has matured more these days so that they can show more promise, but I am looking forward to seeing more data before I become more excited. And part of the reason is because we have explored vaccines over the years, including by our group, Chris Wood, who many of you know, was a pioneer in the development of cancer vaccines for kidney cancer and has explored these a lot. We've run such trials and they didn't produce the results we hoped for. However, having said that, the technology now has improved. Thanks. One of the positive aspects of the crazy COVID pandemic is exactly that. It allowed the development of these mRNA vaccine technology that allowed for a more personalized approach. So I am intrigued and looking forward to see how these mature. Obviously, I'm biased, and I will say that I'm always enthusiastic about biology-driven trials for rare kidney cancers, knowing about the ones that are ongoing and the ones that are being in preparation is making me very happy, despite anything else that might be happening around the world. So that's one. For clear cell kidney cancer, which is a good paradigm for all of them, or how to think about these things, you can think about it in two ways, the kind of trials and research that excites me. You can think it about, you may have stage 4 clear cell kidney cancer, but as was implied throughout the session today, it may mean different things. You may have a stage 4 clear cell kidney cancer that is very angry, growing very fast, and that needs more intense therapies. Or you may have, again, same name, stage 4 clear cell kidney cancer that is growing very slowly. You cannot manage those two things in the same way, even if they have the same medical term. And for the one that is not growing that fast, perhaps we can gain more benefit by, instead of escalating our therapies, de-escalating, getting more by doing less. And this is something that we have been advocating with Dr. Tang and others, the idea of not exposing patients to preserve their quality of life to systemic therapies early on, and also to delay the exposure of the cancer, because as soon as you expose the cancer, you teach it about that systemic therapy and it will learn to become resistant. So if you delay that, that time point goes further. And we have one of the ongoing trials, we have a randomized trial with Dr. Tang that was supported by the Texan taxpayers, as he knows very well. So we initially called it Texan, but people told us that's too Texas focused. So we decided to call it the Astros trial.
And next to the Jackson, the T was not doing.
Yeah.
But after.
Wait, didn't they cheat?
But after.
I want to change the name of that. So,
Yeah.
are you not going to Google it?
There's a form.
You can see there's no way we could escape creating some excitement with the name. So these are the types of trials, and it's not just us. They're happening both around the country and around the world, trying to see how we can de-escalate, which I think is important. And quality of life is very important for patients. And at the same time, so that's one arm. The other arm is escalating. We're able to make more patients live longer these days and even cure more patients than we used to, but it's far from 100%. And so what we really want to do is get the cure rates one day to 100%. And that's not going to happen by using the same type of therapies that we've been using for the past 10 years, immunotherapy and the chemo pills. We need new modalities, including for clear cell kidney cancer, that are biology driven. And I would say the things that I find very promising is engineering antibodies, for example, the bispecific antibodies, which can bind to multiple targets at once. The technology has evolved so much in the past few years that some of these antibodies are real engineering marvels. It's so much fun just to think and brainstorm the science behind them. So I'm very much excited with the upcoming trials in this space using such technologies for clear cell kidney cancer. The other thing that excites me and others is these cellular therapies, these T cells or NK cells, the CAR T therapies or CAR NK. These have been game changers in blood cancers, but not so much yet in solid cancers like kidney cancer. But I am very confident that this will change. If not this year, it will change in the coming years. So I'm really excited. And part of it is exactly because of this very evolving technology of how much we can engineer these cells, whatever is preventing them from working right now with clear cell kidney cancer, to start working. And then the other one is exactly this small molecule technology now. That's the third one. We now have technology to be even more precise with our small molecule targets. We have these degraders as well and other technology that can allow us to target things that used to be considered completely undruggable, completely. And already we have FDA approvals of undruggable targets, including belzutifan is one.
Yeah.
That used to be thought to alpha was considered completely undruggable. So in the kidney cancer space, you have one example. There are others in oncology. So taking advantage even more of that in the kidney cancer space is what makes me very excited. So I think that the future is bright, but we need to work hard together to accelerate this. We need to bring these therapies at ASAP because our patients need them now, not in 2030.
Can't agree anymore. I mean, it's just so important. And by the way, I'm personally very excited about CAR T-cell therapy, and especially that off the shelf you can buy at Walmart. It's fascinating. And I'm also really interested in casdatifan, that it's a belzutifan too, I call it, but that's going to be an interesting drug. We're going to use the next 10 or 15 more minutes, and thank you guys for your time, just to address some of the questions I see. And I will start with my friend, Michelle. Difficulties radiating the pancreas, since MD Anderson appears to be a leader in dealing with treating mets to the pancreas. I know this is stage 1 through 3, but this is a stage 4 question. Dr. Tang?
Yeah, so we do actually a lot of radiation to the pancreas. It's very well tolerated, and we usually can do it anywhere between it might take up to 2 to 3 weeks in a more complicated case. But we've done very well with radiating the pancreas. And I think the alternative, which is either doing a surgery, it's a lot less than doing radiation. So we've done it a lot. Yeah.
Fantastic. I've seen this question asked. Thoughts about using acetaminophen while on immunotherapy? A couple of studies suggest using this aspirin will decrease its effectiveness. Would you advise avoiding them?
Again, it's a good point. It all depends. It's the same type of answer as what I said about metabolism, microbiome, and diet. You will always find some data supporting something. That's the thing about science. And it can be hard to separate which ones are more legitimate than others. Usually I can guarantee to you, because this is literally our passion, if there is something that we have really strong knowledge that it can make a big difference, we'll let you know. We're not going to hide it from you. And having said that, if you can avoid taking something, including acetaminophen, because you don't need it, then avoid it. But if, for example, it's going to impact your quality of life because, for example, you're having tumor fever that is resolved with acetaminophen, then take it. Don't refrain from taking something just because it may affect the tumor, potentially a tumor response, unless your oncologist gives you specific information. Yeah, in your case, this is important or not, because that's the other thing about tailoring. We can give here general recommendations, but tailoring is the art and the science of clinical practice and the day-to-day.
Yeah, again, I implore everybody listening, including those that will be listening at the taped presentation, you can find a study that will say anything, including our friends that produce ivermectin and all this others, and RSO, Rick Simpson oil. Be careful. There's also the doctrine of functional equivalence, right? Just because you do A and B happens doesn't mean it's because of A. And I think a lot of patients fall for that, right? They read somebody stopped all treatment, they got cured of cancer, and they say that's because I stopped all treatment. So we just all got to be careful about that. This goes back, we've really addressed this, but it really is this emotional side of having these small tumors. I understand your discussion that if the tumor hasn't grown in 6 months, it's most likely benign. But what are the chances of it still being RCC and just not growing at the moment? Regardless of if it's benign or RCC, would it be wise to have it removed while it's still small?
Sure. This comes up a lot for me. So I would say cancerous tumors tend to grow. So if it didn't grow at all in 6 months, then I would be less likely to, so it's 1 point less likely that it's RCC. We can always do a biopsy in this setting, but usually I would want to see growth before I would do that. And as far as patients always ask this, so I try to bring this up when I'm discussing active surveillance, is RCC grows slowly, so we're not going to lose our window opportunity to treat this surgically. Every 6 months is enough time, and a few millimeters of growth will not change the ability to do the surgery. That's a good question that does come up a lot.
No, it goes back to the emotional side of dealing with watch and wait.
And that's fair. And then there's other cancers, prostate cancer, but I treat also as a urologist. Active surveillance was a new thing 10, 15 years ago. And we've published and thought about the patient mental health side of it. So we say shared decision-making. So both the patient and the doctor have to be comfortable with the plan. So if a tumor is at least over 2 centimeters and the patient really can't handle surveillance and we think it's RCC or we've done a biopsy or we're comfortable doing surgery knowing that it could be benign, sometimes I will go ahead and do surgery if I think the patient's very well informed.
I am going to take this last question and then give you guys any final thoughts you have to say. Does MD Anderson do taste procedures for liver mets?
Yes, we do liver taste, and it depends. Sometimes even better, we do what we call radioembolization, where the beads are loaded with radiation. And this has shown better results compared to taste when dealing with liver lesions, not specifically RCC, but in general. The concept is that those tumors are hypervascular by nature. Where you say hypervascular, there's a lot of blood going to it. And we use this concept to deliver our treatment, either chemotherapy and we block the blood vessel, or radiation therapy we deliver to the tumor and we follow up with the imaging also. Yes, but right now there's a huge shift from TACE in general to what we call TARE, basically trans-arterial radioembolization. Again, this is our practice at MD Anderson. A lot of institutions may have different perspectives.
Very helpful. I'm just going to go around the room for final thoughts before I formally thank you. Dr. Cotta, any inspiring thoughts for all of us, I guess, stage 1 through 4 patients and caregivers that are on the phone today?
Sure. Yeah, I would say for stage 1, even through stage 3, that there's a lot of treatment options, and we're lucky that sometimes a local therapy is all you need, and you can have a long-term cure even, which we don't often say, but it can definitely happen, especially with those small renal masses. So we're lucky that we are catching sometimes tumors earlier.
Fantastic. Dr. Tang?
So I think that there's a lot of very interesting and fascinating imaging and biomarkers that are going to be hitting the scene that will define, I think, the care for escalation, de-escalation in a more personalized manner for patients with stage 1 through 4. And then maybe for prostate cancer, for better or worse, the PSA for guidance. Maybe we'll get something like that for kidney cancer. And then people are happy when their PSA is the same number. So KIM1 may be, for instance, but we'll see in the future and I think there's going to be a lot more that we'll see for cancer, and that will really inform the whole spectrum of disease.
Fantastic. Dr. Abdelsalam?
Yeah, what I would love to say is that I know that the word cancer is very scary, and once you hear it, you start panicking. But nowadays, especially with T1A, there's like great chances of being completely cured. When I was doing my research, and I'm sure Dr. Cotta and Dr. Tang and we'll see of them as well, we have patients treated 10, 15 years ago, and they still tumor-free. So there are a lot of good options. Most important key is to find the right person that you get an opinion from. If you have a Tesla, you don't go to Ford to get their opinion on the Tesla. You go to Tesla to fix your car. So it's really important for you to know where to go to get the most expert opinion on your current condition. As I said, there's a lot of good interventions happening, and we're continuously working on addressing bigger and bigger tumors. So I think things are totally different compared to what it was in the past. Just you have to find the right place to.
You make such a critical point. I always tell people, you want specialization. You don't want a doctor that's done 22 nephrectomies, does 25 other things, or no offense to general oncology, but they don't know the clinical trials that are out there for renal cell carcinoma. You've got to, and I have a bias towards big city hospital academic centers. So I assume you guys would agree. Dr. Msaouel, you can give me book and movie recommendations later. We did see The Accountant too, but inspiring thoughts for all of us.
Yeah, and I'm looking forward to watching Thunderbolts hopefully this weekend. I'll keep you posted, everyone. But thank you all for having us. Really, every day we do see proof that progress is real and it is accelerating. We've got new targeted drugs, smarter immunotherapies, and blood-based tests even are to catch relapse of the disease earlier, are moving from the research benches to the clinic rooms faster than ever. And that's because patients, clinicians, scientists, and advocates keep pushing together. So if you're living with kidney cancer, know that you're not alone. Options keep expanding. Your voice matters. And hope in kidney cancer is not abstract. It is measured in longer remissions, gentler side effect profiles, and brighter tomorrows already in our horizon. So we remain committed to turning today's science into tomorrow's cures, and we're honored to stand beside you on that journey.
Thank you so much. When I was a kid growing up, my heroes were sports heroes, were sports players, except for the Houston Astros who cheated and beat my Indians/Guardians in the playoff. It's interesting. I'm awestruck just being among this group and having you guys dedicate 2 hours of your time to us and a larger group that will be listening when this is audio tape. You guys inspire me and give me hope as a stage 4 patient. I wouldn't be here, but for everything that you and others are doing for the stage 1 through 3, keep trying to get us those cures and keep us from getting progression. But I've learned so much today, and I thought I knew a lot. And the more I hear you guys talk, the more I realize I have a lot more to learn. I would guess everybody here would say the same thing. Thank you so much. Keep doing what you're doing. And I do hope to come out to Houston and see you guys again later. Thank you.
Bye. Thank you.
Thank you for having us.
Welcome. Thank you, Linda.
Thank you, everybody. Bye.